Welcome to this education video entitled Assessment and Management of Youth Depression. This session is a component of our Primary Care Behavioral Health Primer Education video series designed especially for pediatric primary care providers. My name is Megan Benoit Ratcliffe. I'm a pediatric psychologist with Children's Healthcare of Atlanta, and I'm delighted to be your presenter for this session. A bit about me: I'm a pediatric psychologist with 9 years of postgraduate experience, working in both inpatient and outpatient settings across a variety of illnesses and conditions. Caring for those in need is, I believe, one of the highest callings. I hope that you'll be able to take away from this series information and ideas that will help you in the important work that you do. A brief disclaimer: this program offers general information and is not specific medical advice. Always consult with a doctor or other healthcare provider if you have any questions or concerns about the care or health of a child. In case of an urgent concern or emergency, call 911 or go to the nearest emergency room right away. For immediate concerns related to a patient suffering from depression or other behavioral health crisis, call the Georgia Crisis and Access line at 1-800-715-4225. This line is staffed with professional social workers and counselors 24 hours per day, every day, to assist those with urgent and emergency needs. I do not have any financial relationships or other conflicts of interest to disclose. The primary objectives for this presentation are to discuss up-to-date information on youth behavioral health and mental health risk factors, specifically related to youth depression, to identify unique strategies for youth and caregiver assessment of behavioral and mental health issues, and to develop a plan for managing and triaging behavioral health and mental health issues within the parameters of your current practice. This youth depression series is segmented into 4 sessions. The first session provides a depression overview. The second session provides assessment strategies and differential diagnosis. The third session provides information on how to incorporate caregivers in the assessment and treatment of depression. The fourth and final session provides information on how to assess and treat youth presenting with depressive symptoms. Let's begin Session 2, Assessment Strategies and Differential Diagnoses. How you assess for depression can make a big difference in whether or not cases are accurately identified. One helpful strategy is to pre-screen in the waiting room. There are several advantages to pre-screening. Youth might feel more comfortable filling out a pen and paper or online evaluation than responding to verbal inquiries, especially if parents are present. Screeners also highlight significant concerns in advance so that you can prioritize time during the visit to the most pressing issues. Many practices opt to give out screen only during well-child visits, given the brief amount of time and other focus of sick visits. Another common practice is handing out a brief note with a screening instrument, detailing the purpose of the screening and making it clear that screening is voluntary, and like all other medical information, confidential. The U.S. Preventive Service Task Force recommendation is that all teens 12 years and older should be screened when systems are in place to ensure accurate diagnosis, therapy, and follow-up. For youth between the ages of 7 and 11, evidence is insufficient to warrant a recommendation for comprehensive screening. Insufficient evidence does not mean don't do it, but that the information obtained may be less reliable depending on factors such as reading level and comprehension. Several assessment instruments have been recommended for use for depression screening in primary care. These self-report screeners can be completed within 5 minutes by patients and caregivers and can be scored quickly by office staff or clinicians. It is important to note that short screening instruments provide a good initial impression, but not a definitive diagnosis of depression. Several scales to consider for use in your practice include the Kuchar Adolescent Depression Scale. This is a 6-item scale designed for use in research and institutional settings. Despite its brevity, it has been found to be as effective as longer screening instruments, such as the Beck Depression Inventory, in identifying depression among youth ages 12 and older. The Patient Health Questionnaire, or PHQ-2, asks 2 simple questions about mood and anhedonia. Similar to the previously mentioned scale, it is as effective as the 21-item Beck Depression Inventory in identifying depressive symptoms among those 12 and up. A 9-item version is also available that is able to even more accurately identify at-risk cases. The Child Depression Inventory is a 27-item scale for children ages 7 and up and their caregivers. The benefits of the Child Depression Inventory are that it extends to a lower age and includes caregivers as an alternate informant. Drawbacks include that because it's not public domain, it must be purchased, and that it is longer in length and thus a greater burden to complete. The Pediatric Symptom Checklist is available in both 17 and 35 item versions. It is available for youth ages 11 up and their caregivers. Besides depression, it assesses for ADHD, anxiety, and oppositional behaviors. Research has provided evidence for the efficiency and effectiveness of these scales in screening for depression in clinical practice. Here is a basic flowchart of assessment logistics. As previously mentioned, pre-screening in the waiting room may be beneficial, but it is not required. Even if the pre-screen comes back negative for depressive symptoms, you may want to assess for depression face-to-face. There is ample data about how mode of administration can affect response in both positive and negative directions. The 2 questions listed here: over the past 2 weeks, how often have you been bothered by 1, little interest or pleasure in doing things, and 2, feeling down, depressed, or hopeless, are the 2 questions that make up the patient health questionnaire from the previous slide. These 2 questions taken together have a 74% sensitivity or true positive rate, meaning 3 out of 4 teens who endorse these items will have a true depression diagnosis. Additionally, these 2 questions have a 75% specificity or true negative rate, meaning that 3 out of 4 teens who do not endorse these items do not warrant a depression diagnosis. Asking these or similar questions can validate a negative pre-screen. A positive pre-screen or affirmative response to these general questions warrants more comprehensive assessment of symptoms and appropriate triage. Regardless of the screening result, be sure to document your assessment and, if relevant, your treatment plan. After you have assessed and classified your patient's symptoms as absent, mild, moderate, or severe, it will be important to appropriately triage care. Using shared decision-making, a collaborative approach between you, the teen, and his or her family may be helpful because it allows families to choose treatment options that they are more likely to adhere to. Reasonable treatment plans based on mild symptoms would be to refer to therapy, to encourage teen and family to engage in self-help, such as reading books like When Nothing Matters Anymore, a survival guide for depressed teens. You may also, after talking with a family, decide to monitor the teen, scheduling him or her for a follow-up visit in 3 to 4 weeks. Therapy and/or medication are reasonable treatment plans for youth presenting with moderate symptoms. These can be done in unison, or the family may decide to pursue one option over the other. Neurobiological differences in who responds to which type of treatment are still poorly understood, though efficacy rates appear to be about the same in the short term for symptom remission. Severe depression may require an immediate response, particularly if a teen is presenting with psychosis, active suicidal ideation, and/or a plan with means to execute it. You may need to consider the family's capacity to proactively manage the youth's mental health needs. If a teen is in imminent danger to self or others, or a teen or caregiver reports not feeling safe to go home, psychiatric hospitalization might be required. Families may be referred directly to a psychiatric hospital, or they may be referred to a local emergency department. A 1013 authorizes police to transport individuals to an emergency receiving facility in an emergency. An immediate referral for psychiatric and/or psychological treatment should be made if there is no immediate threat of harm. It is important to understand differential diagnoses when considering whether a depression diagnosis is warranted. This can be helpful in terms of treatment planning and in educating families. The DSM-5, released in 2013, has significant revisions from earlier versions. Some of the updates will be presented on the next several slides. Please note this is not an exhaustive list, but a place to begin considering other disorders that may share symptoms with depression. Persistent depressive disorder is a new diagnosis in the DSM-5 that merges dysthymia and chronic depression. It is characterized by depressed mood that occurs for most of the day, for more days than not, for at least 1 year for children and adolescents. It is notable for its chronic course and an early and insidious onset, in other words, by early adulthood. Major depressive episode may precede persistent depressive disorder, and major depressive episodes may occur concurrently with persistent depressive disorder. The consequences of persistent depressive disorder are increasingly recognized as grave. They include severe functional impairment, increased morbidity from physical disease, and increased risk of suicide. Disruptive mood dysregulation disorder is a new diagnosis in the DSM-5. It is characterized by irritability or angry mood most of the day, nearly every day, and severe temper tantrums or uncontrolled rages 3 or more times per week, with symptoms lasting for at least 12 months. Symptoms begin before the age of 10, but the diagnosis is not given to children under 6 or adolescents over 18. It is more common in males, with an estimated prevalence of 0.8 to 3.3%. Premenstrual dysphoric disorder is characterized by irritability and mood swings in excess of what might typically occur during premenstrual syndrome or PMS, with symptoms occurring within 1 week onset of menses, with improvement several days after onset. Adjustment disorder with depressed mood involves mild depressive symptoms not meeting full criteria for depression, with symptom onset within 3 months of a triggering stressful event, plus either marked distress that is out of proportion to the severity or intensity of the stressor, even when external context and cultural factors that might influence symptom severity and presentation are taken into account, or 2, significant impairment in social, occupational, or other types of functioning. Symptoms typically resolve within 6 months and functional impairment is limited. Seasonal affective disorder is a major depressive disorder specifier in DSM-5 rather than its own diagnosis. It is characterized by low mood and energy associated with seasonal changes. This is more common in fall and winter months and in geographic locations that receive less sun. The seasonal pattern specifier must meet 4 criteria: depressive episode at a particular time of the year, remission at a characteristic time of year. The pattern must have lasted 2 years with no non-seasonal major depressive episodes during that same period, and these seasonal depressive episodes outnumber other depressive episodes throughout the patient's lifetime. Bipolar disorder is characterized by manic or hypomanic episodes alternating with depressive episodes. Episodes are more extreme than typical mood swings and are accompanied by changes in sleep, energy level, and the ability to think clearly. Youth presenting with bipolar symptoms may strongly overreact or become agitated or aggressive with little instigation. They may have grandiose ideas and act impulsively. During a depressive episode, they may be more likely to complain of physical symptoms, like aches and pains. They may also cycle more quickly between depression and mania, sometimes within the same day. Bipolar symptoms are so strong they can make it hard for youth to do well in school or to get along with friends and family members. The disorder can be dangerous. Some young people with bipolar disorder try to hurt themselves or attempt suicide. Bereavement is often triggered by a specific loss, such as the death of a loved one. Painful feelings come in waves, often mixed with positive memories of the deceased. In depression, mood and ideation are almost constantly negative. Self-esteem is also usually preserved in bereavement. Bereavement, like sadness, is a normal response. It is when it becomes overwhelmingly debilitating and/or very long in duration that depression might be considered a reasonable diagnosis. Non-suicidal self-injury is defined as the deliberate self-inflicted destruction of body tissue without suicidal intent and for purposes not socially sanctioned, such as ear piercing. It includes behaviors such as cutting, burning, biting, and scratching skin. It is prevalent during adolescence, affecting 17 to 18% in recent community samples. The relationship between non-suicidal self-injury and suicide is nuanced and complex, with some studies suggesting a higher likelihood of lifetime suicide attempts among those who engage in non-suicidal self-injury. Substance use is a risk factor for depression, but it can also be responsible for some of the symptoms, including sleep difficulties, changes in appetite, and psychomotor agitation. Understanding if drug use is the cause of symptoms or an attempt to self-medicate is important in deciding on the best course of action for treatment. Other medical issues, such as thyroid disorder, can present with symptoms that mimic depression. It is important to assess for physiological causes using laboratory tests and physical examination if you suspect other medical issues may be involved in symptom presentation. For more detailed information on youth depression, including differential diagnoses, please visit these quality websites. This concludes our second session, Assessment and Differential Diagnosis. The next session, Caregiver 411, will focus on how to incorporate caregivers into assessment and treatment of youth depression. We hope that you found this video useful and informative. From Children's Healthcare of Atlanta, we thank you for watching this video.